Hi, welcome to the @IM Bedside. This is a series of videos in which we will focus on clinical questions that arise while you're taking care of your patients. This is part of our curriculum for the ICU, in which you're going to be using these videos as a conversation starter for further discussion that should happen at your bedside rounds during this week. For our first video, we wanted to discuss shock, undifferentiated shock. Alright, so what is shock? Shock is the collapse of our circulation that leads to ineffective delivery of oxygen to the tissues. How do you decide if your patient is in shock, right? So one of the things that can help you is objective measures, blood pressure mainly. One of them is your systolic blood pressure being less than 90, or your MAP being less than 70. Those numbers should trigger some alarms in your mind. However, the most important thing is to look at your patient. Are they exhibiting clinical signs of circulatory collapse? Because not all patients are gonna necessarily fit those criteria, right? If your patient's more hypertensive, it might take a long time for them to be below 90 on their systolic blood pressure, but their physiology of hypoperfusion is already there. So how can you be more effective? Okay, so first look at your patient, or step one. So first things first. There are three places that can tell you a lot about perfusion. Those three places are skin, brain, and kidney. They can help you on top of those objective numbers to tell you if your patient is not perfusing well. So obviously first here, most important, the kidney. So remember the mantra, no BP, no PP. If there's no perfusion, there will be no urinary output. So when you're taking a look at your patient, look at the Foley bag or put a Foley in if you don't have that information. Next is the skin. Is the skin cold and clammy? Is the patient cyanotic? Is there any signs of ischemia there? With perfusion, you can see through the skin. The third one is the brain. So how is your mental status of your patient? Is your patient confused? Is your patient upturned? Those questions are going to help you answer the question. Is my patient in shock? Okay, let's say that all of those things are apparent, that the patient's not having perfusion. All right, my patient is in shock. So don't panic. We need to keep our patient alive. Don't look at the monitor. Remember, look at your patient. So before you try to narrow down the type of shock, again, you have to have a living patient to be able to have a management plan. So your next step should involve A, keeping the patient alive, and B, figuring out the inciting cause at the same time. So how can you do that? So first of all, to not panic and slow yourself down, remember your basics. Go back to your ABCs, right? Your airway, your breathing, circulation. Keep your patient alive while you gather a little bit more info. And ask yourself at this point, does this patient need to be intubated? Does this patient need more fluids? Does this patient need pressors, right? To support those three vital things. While you're thinking about this, try to narrow down which type of shock your patient has. So let's go back to the good and old medicine. That should be your best ally here. I'm talking about having a good history and a good physical. For example, does the story that your patient tells you suggest an infection? Does it suggest bleeding? Does it suggest a PE or an MI? Also, on your physical exam, remember to check what's your volume status of your patient. Do they have any open wounds? Do they look like they have a flail chest? How does their JVD look like? Third, use your labs and imaging and ask them the same questions. Do the labs point towards a cardiac cause? How does your EKG look like? Are there any signs of bleeding on those labs? Right? So think about all of those kind of together. But again, focus on stabilizing your patient before diving deep and going in to take a look at the chart, right? After you went through your ABCs, got some basic history and objective data, let's go back and put this all together. Let's get focused. So everybody, when you're studying this topic, I'm sure you've seen this table that separates the four types of shock regarding their physiology, right? So we have the cardiogenic, hypovolemic, distributive, and obstructive, and they talk about a couple of things that you can take a look at. So heart rate, CVP, contractility, and SVR. All right. Can you get all this information from just looking at the patient? Probably not, right? Some of them, yes, but you would need to float a swan to get some of those numbers. Sometimes this is very hard, right? We already talked about how sick our patient is, the necessity for you to have a management plan to keep them alive. So not necessarily putting a swan in it at that point is going to be the most helpful thing. And also that doesn't come without their risks, the procedure per se. So there's a couple of things that you can infer. Obviously heart rate, right? But as you can see here, the heart rate does not help you distinguish which type of shock it is. The other one that's going to be helpful is your CVP. Because Obviously, you can measure that, but one of the surrogate markers for your CVP is your JVD. Right? Take a look at your patient, and this is going to help you especially in between distinguishing two types of shock: your septic shock and your cardiogenic shock, because also they are the most common presentations to the ED. More than 60% of the patients come in with shock with sepsis, and the next runner-up with 16 to 20% of the patients is cardiogenic shock. So just taking a look at their JVD is going to help you out plenty. But one of the things that we need to make sure is that we're talking about this here is that this table focuses a lot on physiology. You need to shift your gear from physiology to etiology, or translate this information into etiology. So how do you do that? Put the pieces together. Remember, you already grabbed a lot of information. Try to interpret all this information that you have, right? Look at your physical exam, look at your story, look at your patient. Could this be an MI? Is there an infection? Does it sound like a PE? And use your objective findings, right? And there's a couple of them that can help you. Even if at this point your history isn't clear enough, there's a couple of things that you can do. And one of the most important ones is point of care ultrasound. That can be a great ally. As you can see in this diagram from New England Journal, we can use the appearance of the ventricles and cardiac output to guide us further. As you can see here, this brings you a lot of information. Because, again, on cardiogenic shock, you're going to see large ventricles that have poor contractility, right? Because the main problem is the pump. In contrast with that, on sepsis, which is this distributive shock, as we all know, what goes down is the SVR, right? You have a lot of vasodilation. So your heart's going to be normal, your pump's going to be normal. So you're going to see a normal cardiac chambers and preserved contractility. The other thing that can help you that's not here on this diagram is the IVC, right? What's the volume status of my patient? So you can put the cardiac point of care ultrasound together with the IVC and take a look at their volume status and see if hypovolemic shock. The same thing for obstructive shock, right? You put an ultrasound there, you can see if there's tamponade, you can see if there's something impairing the RV function, then you can think about PE. So the point of care ultrasound, it's key here. Our colleagues at the ED are extremely skillful with this, so please engage them when you're assessing a patient. All right. So let's talk about our plan. A plan for shock should be a VIP plan. Should involve ventilation, infusion, and pressors or inotropes. Right? So let's do it step by step. So ventilation, you gotta ensure the O2 delivery and respiratory support. Most likely than not, your patient's going to need to be intubated, so make sure you address that, okay? Infusion, you're going to ask yourself if this patient needs more volume, right? And make sure you give them volume before you transition to pressors. But sometimes it can be hard to determine how much to give. In our MICU, we have NICOM, and that can help you answer your question. You can also use the ultrasound to guide you and take a look at the IVC to see if your patient's volume resuscitated enough. But engage your attendings in explaining to you and the nurses about how do you use a NICOM to better understand if your patient's volume resuscitated or not. And the third step is the pressors or inotropes. This stage is extremely important. Make sure you're using the right agent for the right problem. It's kind of like if you're going to do your dishes, you should use the dishwashing fluid, versus when you wash your clothes, you should use your Tide Pods, right? You don't use them interchangeably. And when you're taking care of a patient with shock, it's the same thing. Because as we saw in physiology, certain types of shock, SVR is the main issue, and for others is the cardiac output. At this time, you should make a decision about what type of support your patient needs. If you're thinking that your patient needs pressor support, so SVR, nor-epi is our first choice. If you're thinking they need a pump support, so ionotrope, dobutamine is our first choice. We'll talk more about this in a different video. Lastly, don't forget, there's etiology-specific treatments for each type of shock. So for example, if you're treating septic shock, don't forget to put antibiotics. If you're treating obstructive shock from a PE, don't forget to put thrombolytics in your plan. And cath lab for cardiogenic shock. Okay? Now, just to bring back to your rounding this week, make sure you talk about with your residents what questions you have about shock identification and early treatment, and bring those to rounds to your resident and attending so we can close the loop and continue to learn. Thank you.